Hello. In this presentation, I will walk through patient case 2, going through my decision making and my thought process. And as I mentioned with patient case 1, medicine is gray, so you may have approached the case differently. So the patient in case 2 is a 73-year-old woman who was referred to medication management post-hospital discharge. And similar to with case 1, we'll walk through my assessment and plan organized by condition. Starting with her diabetes, her A1C is not a goal of less than 7. From the information that's provided in the case, we don't have a serum creatinine, so we would benefit from checking that because of metformin and her age. So this would be a medication-related need of safety. The MTP category is needs additional monitoring, and the rationale is that the medication requires monitoring. And then assuming that her estimated GFR is okay, we have another medication therapy problem related to metformin, and this medication-related need is effectiveness. The MTP category is dosage too low, because she would benefit from titrating up the dose of metformin to the therapeutic dose of 2,000 milligrams daily. She could take it as 1,000 BID by increasing it by 500 milligrams weekly as tolerated, and then of course taking it with food. If she is okay to take it twice a day, this would be her only medication that's twice a day. She could or might benefit from continuing to take it twice a day, considering that she did have some previous GI upset. For hypertension and coronary artery disease, her blood pressure today is not at goal of less than 140/90 per JNC8, and it's also not at goal of less than 130/80 with the 2017 AHA-ACC guidelines. However, her blood pressure was previously at goal, so we may not recommend a change since this is her only one reading that's not in goal. But on the flip side, we could consider increasing lisinopril for renal protection. So lisinopril's renal protection starts, around 10 to 20 milligrams a day, and her blood pressure could likely tolerate this increase. And if we do increase lisinopril, we'd want to recheck her blood pressure, of course, and BMP to get the serum creatinine and potassium in 1 to 2 weeks after increasing the dose. Looking at her other medications, the patient is on preferred therapy post-MI. She's got a beta blocker, she's got an ACE inhibitor. The clopidogrel is indicated given her stent was within a year. And she is also at goal of being on a high intensity statin given her clinical ASCVD. And we would also want to ask her about her nitroglycerin use. She was recently admitted to the hospital with new onset AFib. She was started on warfarin 6 days ago. So this is a medication-related need of effectiveness and safety because we want to check an INR today so that we can further assess therapy for both effectiveness and safety. The INR today would determine our next steps. And then she would also benefit from education on what increases and decreases the INR. For allergies, she would benefit from education on avoiding both taking the chlorpheniramine and the diphenhydramine. We're likely able to discontinue chlorpheniramine given her infrequent use, but we do have some concern for those anticholinergic side effects given her age. So this would be a medication-related need of safety. The MTP category is adverse medication event, and the rationale is that it's an unsafe medication for the patient. The patient reports using the diphenhydramine for sleep, but I would also put it in this medication therapy problem category because of those anticholinergic side effects. And we would definitely want to talk to her more about her sleep. For immunizations or prevention, the patient is a candidate for the Pneumovax 23. She already had Prevnar 13 a year ago, and the Pneumovax 23 is then due a year after the Prevnar 13. She would also benefit from a yearly influenza vaccine hepatitis B, and Tdap, depending on when she last received it. And again, if she hasn't had all of those already, she would be a candidate for them. So the medication-related need is indication, the MTP category is needs additional medication therapy, and the rationale is preventive therapy. There are a few conditions and medications that we need more information so that we can make assessments and recommendations. We touched on the diphenhydramine and sleep, so we would want to know more about her sleep and what's her sleep hygiene like. It would be helpful to know what other agents that she's tried for sleep. We'd also, I think, would be helpful to know if she's seen a behavioral health provider, because we know those behavioral interventions are first line and have better evidence for treating chronic insomnia. We'd also want more information about her heartburn or GERD symptoms. Does she really need a PPI? And for her arthritis, we'd want to assess her pain control and see how often she's using the acetaminophen PRN. So these were my thoughts as I approached the case. Again, I hope you found it helpful to walk through the case and how I identified and classified the various medication therapy problems.